Welcome, everybody. Thank you for joining us today. My name is Cheryl Fatibene. I'm the Chief Nurse Practitioner Officer at the NNCC, and on behalf of the National Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn webinar. It's part 2 of a series, Patient Safety in Primary Care Settings, Medication Management, and the Warm Handoff. Our presenter today is Dr. Kelly Smith, Scientific Director for Quality and Safety and co-PI of AHRQ's Guide to Improve Patient Safety in Primary Care Settings by Engaging Patients and Families. Today's webinar is being recorded and will be available in the upcoming week on our NPSAN portal page, and a link to the recording will be sent to all of you that have registered. For those attending the webinar live today, you will be able to get CE credit for attending this presentation. Additional information will be provided at the end of the webinar about how to get your CE credit. Again, CE credit is only available for those attending the webinar live today, June the 16th, 2017. All participants will be muted throughout the presentation. I encourage you to submit questions during the presentation. Please use the Questions tab on your GoToMeeting control panel as seen here to ask your question. It will be relayed to the presenters and answered at the end of the webinar. A survey will pop up at the end of the webinar and will be sent in an email later today. Please take a few minutes to complete the survey, evaluating this activity as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available as a handout, which you can access via the Handouts pane in your control panel as shown here. You can click the name of the handout and it will be downloaded via your default browser. Let me take a quick moment to talk about the national investment taking place for quality improvement in the U.S. with the help of our federal government and the organizations who are presenting this content as part of the Transforming Clinical Practice Initiative, which is sponsoring today's presentation. The Transforming Clinical Practice Initiative, or TCPI, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and an enrollment of 150,000 plus providers across the country. The NNCC, or the National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programs to reduce health disparities and meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional membership organization for NPs of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 86,000 members. CMS funded the NNCC and the AANP to support enrollment of nurse practitioners into practice transformation networks, or PTNs, across the country, and to develop clinician-specific educational material that facilitates practice transformation in advance of upcoming payment reform changes. The NNCC and the AANP are the only nursing-focused grantee of the TCPI project. The NNCC and AANP agree that this initiative is important to ensure NPs and other clinicians receive the support they need to remain competitive in a changing healthcare landscape. NPs are the future of primary care in the United States and already provide high quality and cost-effective care. This initiative is an opportunity for clinicians to focus on building the evidence for CMS and the broader healthcare community to demonstrate practice transformation while preparing for value-based reimbursement. Why is CMS funding this initiative? They want to use this program to prepare clinicians across the country for payment reform, in particular payment reform under Macra, the Medicare Access and Chip Reauthorization Act of 2015. Many of you have probably heard of Macra by now. It's legislation that was passed to establish Medicare's Quality Payment Program, or QPP. Under this Quality Payment Program, there are 2 payment adjustment mechanisms to incentivize quality tied to Medicare Part B payments: MIPS, or merit-based incentive plans, and advanced APMs, or advanced alternative payment models. Most clinicians will end up associated with MIPS, or the merit-based incentive plan. MIPS involves 4 elements that clinicians need to demonstrate successfully to maximize their Medicare Part B payments. These elements are to report on quality, to report on resource use, to identify clinical practice improvements or CQI, and to use health IT effectively. Even if you think that Macra and MIPS don't apply to you, if you can demonstrate these 4 elements in your practice, you can succeed in a value-based payment environment. The TCPI and their networks are meant to provide clinicians with the skills necessary to execute these 4 elements in practice. We know NPs have a large growing role in the delivery of health care, especially primary care. NNCC and AANP want to connect NPs and other clinicians to TCPI-funded Practice Transformation Networks, or PTNs. These peer-based learning networks have the responsibility for enrolling and supporting clinicians. They provide free boots-on-the-ground technical assistance and services to help realize practice transformation. How can we, as NPs, help the PTNs by serving as leaders in their networks? NPs are more familiar with many aspects of the change package than physicians. NPs have experience working collaboratively in interdisciplinary, team-based environments. PTNs can provide nurse practitioners and nurse-led health centers with critical resources for practice improvement and access to larger networks of clinical peers. At this point, I would like to turn the presentation over to our presenter, Kelly Smith. Kelly?
Dr. Smith, your line has been unmuted.
Hi, I think you can now hear me. I've got 5 Kelly Smiths up here. So hi, everybody. I'm here to talk today about the Medication Management and Warm Handoff initiatives as part of the Guide to Improving Patient Safety in Primary Care Settings by Engaging Patients and Families. There are 3rd and 4th interventions as part of the guide, and all of the materials that I'm going to talk about today are made publicly available on the Agency for Healthcare Research and Quality's website. So they're all available for download and use. Next slide, please. I just wanted to let everybody know I have no financial conflicts of interest to disclose as part of this speaking engagement. Next slide, please. So as part of our presentation today, we're going to talk a little bit about the threats to patient safety in primary care settings that we identified during our environmental scan for this work, describe the role and the value of medication management and warm handoff strategies to improve patient safety in primary care settings, and identify some strategies and challenges for implementing these particular interventions in primary care settings with patients and families. Next slide, please. Great. So the Guide for Improving Patient Safety in Primary Care Settings was funded by the Agency for Healthcare Research and Quality in 2015 to really look at a way to engage patients and families in ways that improve safety, not just quality. The goals of the Guide are to create opportunities for meaningful engagement between clinicians and their patients and families that they serve. The interventions as part of the Guide are based on evidence, so they come from a robust evidence base. And the goal is to have them adopted in practice with minimal technical assistance. Our project team included patients and family members, as well as primary care clinicians, human factors experts, patient and family engagement, and healthcare professional behavior change experts. And we all worked closely together with our partners at AHRQ in finding and identifying scalable interventions to support improvements in patient safety. Next slide, please. Our key project deliverables, including an environmental scan, 4 case studies of exemplar practices that we identified during our environmental scan, including open notes. We also identified patient and family advisory councils in quality and safety that focused on quality and safety in primary care. Shared decision-making was another key exemplar practice, and team-based care and different approaches of engaging patients and families as part of the team. We also have 4 interventions. We worked with the team to identify 4 interventions to improve patient safety by patient and family engagement. And then we, in January of 2018, will release the final guide. Although all 4 interventions are available and open for everyone to use and give us feedback on up until January of 2018. Next slide, please.
Dr. Smith, I'm sorry, I apologize. There's a little bit of background noise on one of your lines.
Yes, I'm not sure what that is. I'm not typing, so I apologize for that, but it's not on my end.
Okay, all right. I apologize for the interruption.
That's okay. It's distracting, so and if you can get that fixed, that would be great. So our environmental scan identified several key threats to patient safety in primary care. Those included breakdowns in communication, breakdowns around medication management, including patient adherence to taking medications, filling, and prescribing challenges for both the clinicians as well as the pharmacies. Errors in diagnosis and treatment are an emerging area of threat to patient safety, particularly in the ambulatory care environment. And then also opportunities at breakdowns in fragmentation of care and in the environment of care came through. Some of the promising interventions that were identified by our stakeholders, as well as through our environmental scan, include shared decision-making, patient and family advisory councils, various models of team-based care, strategies to improve medication management, of which there were several, family engagement in care, and then structured communication tools to improve bidirectional or tridirectional communication within the primary care setting. Next slide, please. From the environmental scan, we came up with a model of engagement in primary care. And here what we found is that in terms of within the primary care practice itself, the stakeholders of greatest influence on patient safety include the patient and family, the clinicians that care for them, and then the practice staff that support the entire clinic. So the strategies here are represented in the triangle, where they're engaging all 3 stakeholder groups in the improvements in patient safety. And this is happening within the community, the environment, the culture that's within the healthcare setting, as well as the broader healthcare system. Next slide, please. So our 4 interventions that we identified as part of the guide to be include Teach Back, which is an evidence-based approach to improving health literacy for patients and families. Be prepared to be engaged, which is a patient-focused intervention, really looking to get the patient and family members ready for their appointment with the primary care clinician so that we can have some shared setting of action plans and shared understanding of what's important to both the patient and family, as well as what the clinician needs to hear. And today we're going to be talking about medication management and the warm handoff interventions. Next slide, please. Next slide, please.
Hi, Dr. Smith. Just give us 1 second. We'll be moving your slides along for you.
Thank you. So I'll just, there we go, here we go. So I'm going to first start talking about the medication management strategy. Next slide, please. So the goal of the medication management strategy is to develop a complete and accurate medication list in partnership with the patients and family members. Patient and family members, the goal of this intervention is for patients and family members to bring in all of their medications, including over-the-counter medications, prescriptions, and anything that they may still be taking that they perhaps shouldn't be, or taking, sometimes patients are bringing in expired medicines that they're still considering taking or just holding on to because they may end up needing to take that at some point down the future. By working with patients and families, by bringing in your brown bag approach, what we've found is that patients and family members are more engaged in the active building of a medication list, working with the clinicians or the care teams on solutions for overcoming some barriers, and also identifying and correcting safety issues like those expired medicines that they may still be taking, or having potential conflicts or contraindications with different medicines being prescribed by different clinicians. The goal here is really to build on the brown bag approach to medication safety, which has been an approach that's been in place since about 2008, when the Agency for Healthcare Research and Quality originally built a toolkit to engage patients and families to build medication lists. Next slide, please. So you may understand this when we look at medication management in primary care. There are nearly 2.3 billion prescriptions each year prescribed by primary care clinicians. Adverse drug events are also very common, and they may occur in almost 4.5 million ambulatory visits each year. So the medication reconciliation process is a really important safety check, and partly what we really need to do an effective and efficient medication reconciliation is having patients and families engage in that process and bringing in the medicines that they may be taking or that they may be thinking of taking, including those over-the-counter medicines. Next slide, please. So the medication management strategy really is a safety check. It's partnering with patients and families to observe what medicines they're taking, how they're taking them, as well as whether or not they're struggling with any of the barriers to medication adherence, which includes filling prescriptions, understanding why they're taking it, as well as engaging patients and families in a dialogue about where to store medicines and making sure that they're stored and housed at home in a safe environment. Next slide, please. So the one thing that we've done to try to improve consistency and adoption for all of our interventions is that we have the same 5 simple steps for each intervention to get every practice started. So we have an implementation quick start guide that provides some background information on the different medication strategies, the different safety risks that are identified in medication management, and then 5 simple steps to get started, including identifying a champion and getting leadership buy-in, which is critical for any quality improvement program, developing processes and workflows for using the different tools, training team members and initiating an implementation strategy with goals and evaluation metrics, introducing medication management and the materials or the strategies materials to patients and families is also a critical step because oftentimes patients are left out of this particular process. And then the 5th step is really to evaluate, refine, and revise as part of a continuous quality improvement initiative. Next slide, please. So the Quick Start Implementation Guide is a really great place to get started when you're thinking of how do I sell this to my leadership, my clinic or practice leadership. Identifying a medication management practice champion is one way. Once you have leadership buy-in, you can use data from your practice of potential problems with medication management, potential problems with medication prescribing as opportunities for improvement and metrics within the clinical care team. Once you identify your clinical practice champion or your medication management practice champion, you may also want to look at engaging a handful of patients and family members to help you design your process, which is step 2. Next slide, please. So we're right now in the middle of our field test, and for the different interventions, we're field testing in 16 practices across the country. And the field test practices have really identified how to build a strong team for medication management. Many of our practices have identified the team to design and develop their implementation that includes the primary care clinicians, a nurse or nurse practitioner, or some other extended care team member, and then also some of the front desk staff. Not yet have we had any of our practices engage patients and families in that design process, but I think that that's a critical next step for successful implementation. During the design and implementation phase, you also want to identify resources for implementation. What will your practice need? How will you communicate to your patients and families that this is going to happen? And how do you get the message out that really this safety check can save their lives? Next step, please. Sorry, next slide, please. So as part of our strategy, we do have some design support available there with a quick start, and we've had both the quick start guide as well as a design guide for the medication management portfolio. This particular design support has a procedure to engage patients and families in creating the medication list. It has some sample processes and procedures. It has simple 4 steps, which includes a role for staff that when they're rooming and conducting the medicine review, a role for the clinician as they're reviewing the medicine list and discussing any challenges of use that were identified, and then integration of the process with the electronic health record if appropriate. Many of our organizations do have an electronic health record, and they are actually starting with that particular record as part of the reconciliation, and then working with patients and families to go through their brown bags and verifying and validating the information that's in their electronic health record. Oftentimes they're seeing that there's quite a big discrepancy between what the patient brings in and what's actually in the record. So we've already identified some safety challenges within the first 3 months of our field test. Next slide, please. During our focus testing, many of our medical assistants and frontline clinicians who are the first step in working with the patients and families identified that they needed a structure for how to actually go through a medicine review. They were comfortable having a conversation with the patient and family, but they just wanted to make sure that they had a checklist or the accurate steps. So part of our intervention is this procedural guidance to help the frontline teams actually do a supportive safety check and medication review. Next slide, please. So the third step in the process is to orient practice staff and clinicians to the medication management strategy. So for this part, we have fact sheets that provide a really clean, simple overview of what the tools are, how to use them, and how to enhance engagement with your patients and families using those tools. Next slide, please. This particular slide demonstrates what our medication list looks like. Our team stopped reviewing medication lists after we reviewed 75 different approaches to a medication list. And when we put them in front of patients and families, what we realized is that much of what we're asking patients and families to do is way beyond their ability. So what we did was we worked with our patients and families as well as our primary care clinicians to come up with a happy medium. And this is the result of that. Both the things that are prescribed and medicines from their physician, as well as over-the-counter medicines, and really trying to understand and better understand why the patient's actually taking the medicine or why the patient thinks they're taking the medicine, which may not necessarily be the same thing. Next slide, please. We also have a checklist for creating a medication list that really helps to support the process of going through medicines quickly, efficiently, and effectively to identify any challenges or barriers that the patient may be using. Next slide, please. One of our clinician tools that we have for this particular intervention is a common barriers to medication adherence. So really looking at what the patient might say during their interaction with the care team as they build the medication list, and some of the solutions that they might want to suggest the patient try or work with the patient to overcome. It's available in several different versions. We have a full-page version as well as a pocket-sized version that you can just keep in your jacket in the clinic. Next slide, please. So the fourth step in the process is to orient patients. And part of our focus testing, we really realized that patients and family members don't often read brochures. That anything that requires an additional step tends not to get used or read as part of the clinic encounter. So we've created one-page fact sheets as to how to do this, what they're supposed to bring into their next medical appointment, and why it's important to do it. And this has really been helpful to reinforce the need to engage patients and families. Some of our practices have chosen not to actually hand this out to their patients and families, but the clinicians are actually using it as a talking tool, a teaching tool during the clinical encounter as they give them the bag to bring their medicines in at their next visit. So different strategies and different ways of using materials very creatively. Next slide, please. We also built an appointment reminder card so on the back of the appointment reminder card, there's also a reminder to bring in the different medicines that they may be having. And this was something that patients and family members really resonated with during our focus testing. They wanted something they could put in their wallet or throw in their purse so that they would always have it with them and just remember that, oh yes, when I go see Dr. So-and-so or Nurse so-and-so, I'm going to be able to bring in my medicines that day. I have to remember to do that. So it's just another strategy to further engagement and further support implementation. Next slide, please. And of course, the fifth step, evaluate, refine, and revise. Looking at the ways to integrate these into the practice as well as engage patients and families. Some of the recommendations that we've made include doing observations, team debriefing, and simple counts. How many patients are bringing in their bag? How long is it taking? So a lot of different flexibility ways to see whether or not your intervention has been successful. Some of our practices that are adopting this during our field test have already identified safety problems, identified the fact that patients may not be comfortable bringing in their medicines, so working on solutions like taking a picture with your smartphone or potentially bringing in the box that the medicine was in. So there's lots of different strategies that are coming to light during our field test that will be part of the final implementation recommendations for this particular intervention. Next slide, please. So now I'm going to switch gears and talk a little bit about the warm handoff, which is our fourth strategy that was just released in March of this year. So next slide, please. So the warm handoff strategy is similar in concept to bedside rounding on inpatient units. It moves conversations about the patient between members of the care team from outside the exam room to inside the exam room to exchange information in front of the patient and family. That way, what happens is that it's a safety check for the patients and families. We often say in patient safety, nothing about me without me. And unfortunately, in most clinics, the interaction between clinicians and patients is very transactional, and between maybe clinic staff and clinicians is very transactional. Ideally, the warm handoff, it will bring that conversation and that communication between it. I had a recent primary care visit with my nurse practitioner about 3 days ago, and I was, I know better, but I was saying something completely different to the tech or the medical assistant than I did to my nurse practitioner when she came in, just because our relationship's different. And so they're knowing that that communication's already broken down, and I know better than that. So here, a warm handoff would really benefit that kind of environment. Next slide, please. So communication is probably the largest breakdown in patient safety, the key threat to patient safety, whether it's on the inpatient units or out in the community in the ambulatory care environment. Miscommunication and omissions can lead to errors and adverse events on multiple levels, including missed test results or miscommunication of information about the end result of some tests. The warm handoff will increase patients' understanding of the diagnosis and plan of care, engage all members of the team in team-based care, including the patients and families, and it provides patients and family members with an opportunity to validate and verify the information being shared. Next slide, please. So there are many recommendations that we make within the warm handoff. Not all clinics and clinicians are going to be able to move to sort of the ideal model that we adapted from Bellin Healthcare. They're a large health system out in Wisconsin. They do warm handoff really well with engaging the care team coordinator, the clinician, and the patient and family in that tri-directional communication within the exam room. But many of our organizations that are field testing this have tried to do things in a different way. And so you can use a warm handoff during any transition within a primary care environment, including handing off to a scheduler or a lab technician or other members of the care team. So it doesn't necessarily have to be within the patient exam room. That could be a future state, but just getting started with one or two transitions of care that may be problematic for you in your clinic. Next slide, please. So again, this might look familiar. We have 5 simple steps to getting started, including the implementation quick start guide, which does provide some really great background information on the evidence that helps support the need for warm handoff. And warm handoff, the term itself, actually comes from primary care. And it's been used traditionally for primary care clinicians when they're handing off a patient or referring a patient to behavioral health. So oftentimes that referral or that connection to behavioral health in a warm way with a clinician and patient together in that handoff has actually resulted in more success of uptake of the behavioral health. So patients actually follow through with the referral more with a warm handoff than they do without. So again, key steps to getting started are all in the Quick Start Implementation Guide, and that's where we're asking practices to take a look, see if it fits for you, and then get started. Next step, please. So again, from a leadership buy-in perspective, we want to make sure that we have leadership buy-in at the top, because without that, many quality improvement projects just won't sustain. You also really need a good champion here, or a good team champion, to help identify what that process improvement is going to look like. The warm handoff intervention is a little bit more disruptive than the other 3 interventions that we've talked about. And this will really need strong clinician support and adoption. And actually our most successful teams from around the country that have adopted this have had a nurse or a nurse practitioner leading the implementation of warm handoff, and are very creative in how they've actually gone about doing it. Next slide, please. So the second step is to design the implementation. And here I'd like to tell you a little story from one of our field test sites. We had a nurse practitioner from one of our field test sites who was really excited about warm handoff. So excited that she managed to sell it to not only her primary care practice, but also to the health system, the local health system that she works with, to adopt the intervention into practice. So what was really exciting was that they have identified the opportunity to they're using, what are they called, walkie-talkies as a way. So oftentimes the medical assistant will go in, they'll do their debriefing, and then they'll do their briefing and vitals, and they'll check the vitals with the patients and families. They'll step out of the room. But instead of stepping out of the room, they'll use walkie-talkies to identify the next care team member that they want to have come in to participate in the warm handoff. So it's just really being creative and using alternative strategies to help design a process that could be sustainable and overcome some of the challenges of scheduling 3 people to be in one place at the same time. Next slide, please. The third step is to orient practice staff, and again, we have checklists, we have fact sheets, we have posters, lots of different resources that are a very quick read, quick check to move forward with warm handoff. We also, for this, next slide please, we've also developed a video that I'm hoping will work, and it really does better than I can at describing what a warm handoff is and how it can work in practice. So if you can, play the video please.
For anyone interested in watching the video, you may need to turn up the volume on your computer.
Teach back as well, just to demonstrate that it really is, these interventions work really seamlessly together, although you can implement only one and still have an improvement in patient safety. So when we did our focus testing for the interventions, our medical assistant or care team coordinator focus groups brought up that they may not be comfortable in having that conversation. So we did work with them to develop a checklist to support adoption, just on how you would present to a clinician and present about the patient to a clinician to make it efficient and effective. And then also suggestions on how to engage the patient in that conversation as well. Next slide, please. We've also devised a series of clinician and staff handouts that provide some basic information of what the program is and why warm handoffs are important and how they can transform their practice by adopting these types of approaches to tri-directional communication. Next step, please. So for the fourth step, it's orienting the patients. And again, when we were in our focus testing process, some patients were a little hesitant to say, well, you know, I may not want to bring something up to my medical assistant. I'm only comfortable speaking to my clinician about that. And for this, we're here trying to orient a patient and family member about why it's important that everyone on the care team is engaged in that conversation and has the information that they need to make decisions and to work with the patient and family for the greatest success for their health. Next slide, please. And this is one of those interventions that may be a little bit more challenging to identify evaluation metrics around. It's definitely observations and team debriefs, talking through the challenges of implementation, talking through the challenges of what the patient may bring up. Many of our organizations who are testing warm handoff for us are actually entering the warm handoff into their electronic health record as part of the clinical note to say what they discussed and if there were any variations between what information was shared with the medical assistant and then what came up once the clinician was also in the room. Next slide, please. So it's important to link back the importance of these interventions. All 4 interventions, teach back, be prepared to be engaged, medication management, and warm handoff in context with the practice transformation work that's going on nationally. So this slide represents some of the practice assessments for patient and family engagement metrics as part of the Practice Transformation Network. And all of our interventions and materials would actually support improvement in many of these formats, including shared decision-making, improving health literacy, improving the activation of the patient, because improving patient understanding of what they're doing or what you're being asked to do, and to link that into forward movement and adoption is all part and parcel with patient activation, medication management, and then engaging the patient's voice at every transition across the care. So each one of our interventions as part of the guide actually will support improvement in these PFE metrics. Next slide, please. So again, 5 simple steps are all you need to remember. Identify your practice champion and identify which strategy you're going to start with. Plan your implementation, plan and design your strategy, educate and inform patients, families, as well as clinic team members, and then recognize efforts during evaluation, because change is really challenging and it takes a lot of courage to start on this path. So, next slide, please. I think now we have a few minutes open for questions.
So we're going to start going through the questions here. There have been a number of questions that have come in. Just a reminder to everybody that you can type in, if you haven't already done so, to submit your questions via the question panel on your screen. We do have a fair number of questions here that have come in for you, Kelly. So we are going to start with those questions right now.
Okay, great.
All right, Dr. Smith, the first question comes from Mickey. Do you have any idea about how to document in the EMR patient participation in such a double-blind placebo-controlled trial?
So that's a great question. Many of our clinical trials that are ongoing at Medstar Health, where we have the consent documents ported into the EMR, so it's scanned and actually ported in. We are working on an electronic version of our consent forms for clinical trials, but that's a ways off yet. But we are working rather diligently to make sure that the clinical documentation as part of the clinical trial also becomes part of the patient's clinical record.
Great, thank you. The next question comes from Marianne. Marianne is asking, have you ever heard of circumstances in which teams utilize a clinical pharmacist?
Yes, actually that's one of the strongest approaches for improving medication management that we identified. But how to engage the patient and family in that conversation is another challenge, because oftentimes when we've looked at models of clinical pharmacists in the primary care setting, that pharmacist may only be available once a week or part-time. So it's not necessarily, they're not necessarily engaged full-time in the practice and available to do consults. So it is a great model if your practice can afford to have that. Otherwise, creating better linkages with the community pharmacies is another strategy that many primary care practices are working with, and advising patients to really partner with their clinical pharmacist in the community setting and have a consistent pharmacy as well.
And I just wanted to mention as well, in terms of the care team, there's also an additional step of looking at who your care team is, making sure you know and understand all the parts of the team and people know each other. One of the key things I think in a successful warm handoff is making sure that the team all knows each other and are able to introduce one another to patients as well as to one another. I think that will help the whole thing be successful.
It's a great point, Cheryl. The one practice at Bellin Healthcare that we went and we did 2 days of observations at, they work very closely, so every clinician has 2 care team associates who really are the quarterbacks of the team, and their clinician comes in, and so they all know each other very well. They huddle every morning, so there are other structures around that further support safety in that type of collaborative care model.
Great, thank you. The next question is coming in from Deborah. Deborah states, I appreciate the simplicity of the patient med-rec form, but it seems like there should be a column or an area for the prescriber, since often patients are prescribed by their primary care providers and specialists. Any thoughts to that?
So we went back and forth on the complexity, and my team, the team that worked on this actually has a human factors expert on it, and we did go back and forth on the differences of who the prescriber is. and we decided to take it off of the sheet, and I can't recall why we decided it. It may have been for simplicity's sake, but it is something that we should probably consider if that's a critical key component that couldn't be then translated into the EHR. It may be something that we need to add back into that. It's a great suggestion.
Okay, the next question is coming in from Lisa. Lisa asks regarding the brown bag. She asks if they are expensive because she would like to consider taking that strategy at a free clinic that she works at.
So many of our clinics that have started with the medication management strategy, and it is one of our most widely adopted strategies within the entire guide, that they are using plastic bags, plastic shopping bags, because they're easier to hold and easier to carry for patients and families. And oftentimes they've wanted, most of the practices have gone out and had plastic bags branded with their logo. And what they're hearing back from the patients is the patients love these bags. And they're actually incentivizing, the bag itself is an incentive for them to come back and bring their medicines in. So from the practice perspective, the plastic bags are much less expensive than the paper brown bags. But that statement, this brown bag could save your life, is a pretty effective one for practices to have on, just as a visual cue, a visual reminder for patients and families to be bringing in their medicines.
Great. Next question is coming in from Emily. Emily asks, how would you include the pharmacist as part of the care team to account for medication management to avoid adverse drug events if you do not have a pharmacist in the primary care setting?
So that's a really great question, and it really goes to the complexity of healthcare. The goal would be, so the goal of our brown bag strategy is really to simplify the process of getting an accurate medication list. What I would recommend from a transition of care perspective, if the patient does work with a specific pharmacy, because many patients work with multiple pharmacies, that you can create, as a practice, you can create stronger linkages with your community pharmacist to help with the medication reconciliation process. And just to make sure, many practices that have electronic health records will also flag potential contraindications as well. But the first step in that process is actually having an accurate medicine list, and an accurate list in our perspective is what the patient is actually taking, and it may not necessarily be what the patient has been prescribed.
Alrighty, and the next question is asking, is there anything about this medication management tool that addresses the polypharmacy concern of evaluating when patients continue to stay on meds that they no longer need?
So part of our brown bag strategy, again, was to figure out what the patient is actually taking. And so from a polypharmacy perspective, it should identify all the medicines that the patient is currently taking. There's guidance within the medication management strategy to ask patients about whether or not they're taking each medicine, and then how they're taking it and why they're taking it. And that should reveal challenges and identify either expired medicines or medicines that they should have stopped taking after a certain number of doses, but they had enough refills to continue to fill it or something like that. It should help you to identify medicines that patients should no longer be taking, and then that would be flagged on the medicine list, and then that information translated to the clinician.
Great.
So the goal would be to do some shared decision-making around that.
Right, and shared decision-making is so important in the world that we work in. We're going to move at this point to talk about the CE credit portion of today. So I'd like to introduce my colleague Joseph Rise from the AANP to talk a little bit about how you can receive your CE credit for today's presentation.
Hello everyone, this is Joseph with the American Association of Nurse Practitioners. We are very excited to offer the opportunity to obtain CE credit for this presentation. It's a pretty simple process. As you see outlined here, what you first want to do is visit the AANP CE Center. There is a link included in the presentation. You do want to register an account with the CE Center. It is free if you don't already have one. So if you don't already have one, you'll just register for an account, and then once you're logged into the CE Center, there's a product section, and in the product section you'll click My Account. And your information has already been uploaded into the CE Center when you registered for this webinar. And so you're going to be searching for the product titled Patient Safety and Primary Care by engaging patients and families. And then after that, what you want to do is click the steps to receive credits, and there's a special code you have to enter. Now we ask that you don't share this code with anybody else who may not have attended the webinar. This accreditation is only offered for individuals who individually registered for the webinar and attended it live. So please use your discretion with this participation code. And then once you click the code and hit submit, there will be an opportunity to complete the evaluation. The evaluation is what will finally get you access to your CE for this particular webinar. And if you go to the next slide, we do have 2 images that can help display what this process might look like, or will look like. And so if you go into the CE Center, this is a little image, a little screenshot of what it would look like. When you click the My Account tab, you'll see patient safety and primary care settings by engaging patients and families. You'll click that Steps to Receive Credit button, and then once you click that button, there'll be another box that pops up, and you'll see a little code 1 box, and that's where you'll enter the participation code of AANP, all caps, 2673. You'll hit Submit, and then there'll be an opportunity for you to complete the evaluation that's listed below. And then once that evaluation is submitted, you will receive CE accreditation. Now there may be some lag time for individuals who signed up for the webinar within the last hour or so. We'll have to enter your information into the back end of our LMS system, and so that might take a couple of hours, if not until Monday or Tuesday. So don't be surprised if you signed up last minute that you're not able to access the CE Center until Monday or Tuesday. But for those who registered ahead of time, you should have no problem with that.
Great. Thank you so much, Joseph. And I just wanted to, again, do a shout out to the AANP and to Joseph for making sure that CE credit was available for today's presentation. I also want to thank our presenter today, Kelly Smith, for the work that she's done with AHRQ. This is part 2 of a series, and we really appreciate your time and your expertise. I think the thing that we all know and feel as nurse practitioners across the U.S. is that our sense of team and care teams is certainly changing as we work through that dynamic. I think it's important for all of us to be demonstrative in our roles and be sure that we are addressing any inequities we may see in any of our care teams to be sure that it's a level playing field. So, and that's on us and also on our care teams to take that charge. So again, thank you. The next slide here just shows some information for both myself and my colleague Tiffany. This is if you have additional questions either about today's presentation or if you would like more information about the TCPI or more information about the Support and Alignment Network and the work that we're doing here or how we may be able to help you. I would suggest that you go to the link at the bottom first, which will probably answer a lot of your questions about what we are doing as the Nurse Practitioner Support and Alignment Network. And then please feel free to reach out to us, as I said, if you have any questions after the presentation, or if you're having any problems or issues around obtaining the CE content, we can certainly forward those along to the AANP on your behalf. And finally, in closing, again, just a thank you to everybody for joining us today. We will have our next Lunch and Learn next month. It will be on the EHR implementation for small and rural primary care practices. This is designed for both practices that may have an EHR and even those that may have not yet adopted one. This will also be a two-part series. This will be the first part, so we encourage you to attend. Thank you again for everybody for your time, and we appreciate you supporting the work that we do, and please reach out to us, as I said, if you have any additional content or information you would like to see covered. And with that, I'm going to close the webinar for today. Again, thank you for your participation. And thank you, Kelly.